Hello, my name is Peter Boehm. I'm a partner of the Erlanger Neurosurgery and Spine and the medical director, and I've been asked to give a talk today with regards to some different subjects in neurosurgery. The neurosurgical subjects are broad with regards to the options to choose from. We treat all kinds of issues in neurosurgery, from vascular to tumors to trauma, fractures. But one of the most common things that we see in our clinic from an outpatient standpoint on a daily basis is back pain. It's an incredibly broad topic, and in this short period of time, I was going to try to give an overview to walk you all through how we think about and approach managing back pain. And it's quite a challenging subject. It's quite varied, but hopefully this will give you some clue as to how we approach things and ultimately treat both conservatively and surgically. I have no disclosures with regards to this topic. From an overview of the presentation, I'm going to talk about what I call the conundrum of back pain. We'll look at some basic anatomy, both to review the anatomy, but also the anatomy is important from a pain generator standpoint. We'll also look at some terminology that I think is confusing from a patient standpoint, as well as what we say in our notes, as well as what's in the radiology notes. And I think it's important to understand exactly what some of these terms mean. We'll look at some pathology of the degenerative lumbar spine, as well as some treatment options, again, both conservative and more invasive and surgical. And then lastly, we'll tie it all together with a few cases to bring it home. So the conundrum of back pain is, how is it possible that this is an MRI T2 weighted on both ends, two different patients. How is it possible that the image on the left has minimal to no back pain, quite tolerable, functions very well on a daily basis, and the image on the right, which is virtually a perfectly normal appearing MRI, and has tremendous and intractable back pain? And this makes it very challenging for us to manage and also explain to patients. They don't like hearing when, well, your back looks pretty good, but it hurts on a daily basis, and they're miserable from this. And how do we approach that? So starting with anatomy, we've all seen the anatomy at some point in time in our careers, and this is not going to be an extensive overview, but it will be appropriate from localizing certain abnormalities as well as understanding certain pain generators. So 3 images. We use MRIs quite a bit. It's really the gold standard with regards to evaluating back pain. X-rays are used as a very quick screening tool. Myelograms still have a role these days, especially in patients with pacemakers that are not compatible, or other certain pathologies that we may need to look at further. But the MRIs is really the gold standard to tell us, is this something that is just a degenerative process? Are we dealing with something more trauma? Are we dealing with a tumor? So the MRI is the best tool we have. And looking at the left image, and this is just a brief overview, the rectangular red block is the vertebral body. The cushions in between are the disc spaces. And this MRI shows a relatively healthy appearing spine with a good hydrated disc space. The heights are all well maintained. There's minimal bulges. In the middle screen, we have a T2 axial image. Again, the red oval in the center is the spinal canal, which houses the nerve roots. And in the lumbar spine, the spinal cord ends around L1-2, and everything inferior to that is the cauda equina, or the nerve roots, as they exit out each level. On the left are the facet joints, or the facet joints bilaterally, but on the left they're marked. And they have the medial and lateral facet joints, and that makes up the joints of each spine. So essentially, there's 3 main joints at each level. There's the disc space, which can act as a joint, and the facet joints. And on the top right, this is another T2 axial that shows the exiting nerve roots. And at each area of these sections, both the left, middle, and right images, these are all various pain generators, and that's not limited to those. The pain generators can be the paraspinous musculature that you can see On the middle screen, the psoas muscles. The paraspinous musculature can also be a significant source of pain. Remembering our dermatomes, this is an area of skin that is supplied by a single spinal nerve root. When patients come in and talk to us about a pattern of pain, they may talk about back pain, but they may also describe a pain that radiates into the right hip and down the leg to the knee. And in my mind's eye, I'm thinking an L4 nerve root. They may describe pain down the back of the leg that goes into the top of the foot, and I'm thinking an L5 nerve root. So it helps in our mind's eye, even before we see the imaging, to think about where the abnormality or where the compressive pathology may be. With regards to the myotomes, these are the muscles that are supplied by a single spinal nerve root. These also will help with localization, and they may be associated with weakness. Sometimes people will describe a boring type pain, a deep pain, and that's different than a dermatome pain. That may be a myotome type pain as well. Again, in our mind's eye, if somebody complains of a deltoid weakness or a foot drop, then we're immediately going to think about a C5 for the deltoid or an L5 for a foot drop. Sometimes it's quite difficult to assess for weakness if patients are in a significant amount of intractable pain. Their whole leg may appear weak, and it's difficult to assess a specific myotome. Looking at underlying causes for back pain. Most commonly, there's no specific cause found. People are very frustrated that something happened to their back. They don't understand what they did. They simply woke up with the pain. They thought that they slept wrong, have a little tension in their back, and it progresses to quite significant back pain over the course of days. Sometimes they bend over to pick up a sock. They decide they wanted to turn left when they turn right, and all of a sudden their back goes out, and they say that they're on the floor for several days. Oftentimes they talk about overdoing it, whether working in the yard or taking on a new exercise regimen. Most of the time, it's simply just a progression of degeneration over the course of time. Often age-related changes that are most commonly seen in the older population. However, as we are seeing the younger population with regards to obesity and morbid obesity, along with type 2 diabetes and other chronic illnesses that are starting to show up in kids, the spine is also very similar. We're starting to see younger kids in the 12, 13, 14-year-olds that are morbidly obese that are starting to show very early degenerative changes, and that sets them up for long-term problems. Causes can be muscular or myofascial strain. Again, an MRI that looks quite good and quite normal and is isolated back pain is often a muscular or myofascial type strain. Oftentimes it is multifactorial. The spine has quite a dense population of pain receptors out of proportion to what you would think in the bones and the joints and the disc spaces. And there's also a significant inflammatory response even to a minor injury that can really exacerbate the symptoms that patients are describing. Sometimes the causes are very specific. It can be a disc herniation, an annular tear, which deserves some attention, and we'll touch on base on that later, and fracture. Somebody with an acute onset pain, even without a known fall, especially in the older osteoporotic population, an X-ray or an MRI needs to be done to rule out a fracture. Most commonly, people do not know of a specific cause, and the cause is largely unknown. So looking at some terminology and some pathology. Terminology is often very confusing. Patients now have significant access to their radiology reports as well as our notes, and sometimes the terminology that we list and the terminology that's read in the radiology report is very confusing and often very concerning to patients. The terminology in the radiology report needs to be remembered that they are just reading what they see. Sometimes it is clinically relevant, sometimes it is not clinically relevant. But things that we're going to look at over the next several slides include terminology like osteoarthritis, spondylosis, degenerative disc disease, spondyloarthritis. When it comes to disc pathology, it's often very confusing. Patients don't understand the difference between a bulge or a herniation. protrusion, extrusion, or even a sequestrated disc fragment. And we'll go over that. Looking at words like osteophytes and stenosis, facet joint cysts, spondylosis, and spondylolisthesis are all terms that pop up quite frequently, but whether they're actually clinically relevant or not is sometimes difficult to assess and sometimes difficult to talk to patients about because they see a pathology read in a report, but it doesn't match their clinical symptoms and is often an incidental finding. So looking at this spine that was shown earlier, this spine kind of explains and shows a lot of different pathology. We have in the upper disc level a degenerative disc disease. There are some Myotomes plate changes in the vertebral bodies. There are some disc bulges. There are some bone spurs. But all of this is all under the umbrella of degenerative disc disease, spinal osteoarthritis, spondylosis, spondyloarthritis. And these are all various ways of saying the same thing. It's just an umbrella of arthritis. It doesn't tell us anything about whether these are clinically relevant or not. I think that discs often cause a significant amount of confusion with regards to what is actually, being said and what it means. So running through this, in the top left image, we have a disc bulge. And disc bulges are not disc herniations. It is a degenerative process where the disc itself starts to lose its water content. You can see that the two discs above have a nice hydrated look to them. And then there's some darkening of that disc in a bulge. The disc loses its turgor and the discs collapse a little bit. And it's a circumferential bulge. Then you move from there, a disc can have a disc protrusion or a disc herniation, and those are often interchangeable. And a disc protrusion is when the nucleus pulposus, the soft cushion inside the disc, protrudes out of its location, but is still covered by the annulus. And that's the middle right picture there showing a disc protrusion or a disc herniation. When you look at disc extrusions, that's when the disc material, the nucleus pulposus, actually breaches the annulus or the fibrous covering and herniates out that direction. When we get into a sequestered fragment on the bottom left, that is when a disc herniation actually extrudes out and then the fragment is broken free and is actually separate from the disc space. Oftentimes, sequestered disc fragments have a really good chance of healing on their own because they're separate and can be broken down by the body. Far lateral disc herniations are important to keep in the back of your mind, often missed on radiology if you're not specifically looking for it. And then something worth mentioning is the annular tear. Annular tears can wreak havoc on the back. It's amazing how something so small can cause so much issue. But in the bottom right image there at L4-5, you see a little white, what we call hyperintensity at the back inferior aspect of the disc space. And that is an annular tear. That is a fissure in the annulus, the fibrous outer covering, and is a weakening. The inflammatory response that this causes is tremendous, and it can cause significant muscle spasms. It can even irritate nerve roots and cause a radicular type picture. There's nothing to do for this surgically. This is simply something that needs time, anti-inflammatories, physical therapy, all which we'll discuss in a second. Stenosis also causes a lot of concern. People get worried about stenosis, and sometimes it's reasonable, but sometimes the stenosis is something that is a chronic process. You can have canal stenosis that as a result of a disc bulge, a disc herniation. Again, the stenosis doesn't describe the underlying cause. It is simply a description of narrowing of either the spinal canal or the neural foramina where the nerve roots are coming out of the spinal canal. On the bottom picture there, that's an example of significant stenosis being caused by a facet joint cyst. And a facet joint cyst is also a significant pathology. It causes similar radicular type pictures that a disc herniation would. And it's exactly the same thing as a ganglion cyst at the wrist or a Baker cyst at the knee. It's simply an outpouching of the synovial cyst that is causing compressive pathology. Moving on with some additional terminology in pathology, spondylolysis oftentimes comes up. We see it in children, especially young athletes, and we often see it later on in adulthood as an incidental finding. And it can be congenital, meaning that you're born with it. It can also be traumatic. And sometimes it's difficult to differentiate whether it was traumatic or congenital unless there is another normal scan that was taken prior to any X-rays or CT scans. The CT scan is the best scan to show for spondylolysis. And what that is it is a break in the pars, which connects the inferior joint to the posterior elements and thus the vertebral body. So in that top left picture, that's an L5, what we call pars defect or spondylolysis. There has not been an acquired spondylolisthesis, but the image on the top right does show what happens over the course of time, or can happen over the course of time, with regards to a spondylolysis or a pars defect. That could cause an instability and ultimately result in a spondylolisthesis. Commonly, people throw out the term a slipped disc. It's actually a slipped bone. It's when one bone slips forward on the other and can result in significant back pain as well as radiculopathy. Spondylolistheses can also be associated from a degenerative standpoint. It's not always a pars defect. Simply the joints, facet joints in the spine do not, they become incompetent and they don't hold the vertebral bodies in place. And over the course of time, that bone slips forward and ultimately crowds the nerves and causes significant muscular issues. And there's an example of a spondylolisthesis from a degenerative standpoint on the bottom two images there. So what are the treatment options? And these can vary from very conservative to very invasive and surgical and everything in between. So when always possible, it is always best to put surgery as a last resort and start very conservatively. The conservative treatments are start with very non-invasive, almost kind of common sense approaches that we all attempt to treat. One is lifestyle modification. So if you're really into gardening or yard work and spend 8 hours a day and then 3 hours in the bed, that may be something to think about altering. If you've picked up, a new bout of CrossFit and everybody's lifting heavy weights, and every time you're going home, you're in bed for 3 days, that's something that maybe need to consider. Doesn't mean stop it. It just means alter how you're taking, how you're approaching these, hobbies or new exercise regimens. Occupation is a significant problem. People have a good job that they want to keep, but it's, significant amount of repetitive bending, heavy lifting, that not everybody can do for long periods of time. And I tell people all the time that, as hard as it is, that an occupation change may be necessary. In addition to lifestyle modification, over-the-counter anti-inflammatories as well as prescribed anti-inflammatories are really standard. Not everybody is a candidate for anti-inflammatories, but over-the-counter Aleve, ibuprofen, Tylenol, a Medrol dose pack, those are all excellent anti-inflammatories that can be taken, for acute pain in short courses with meals to protect the stomach. In addition to the medicines, as we all know, the therapies are a significant part of conservative treatment and are often mandated by insurance companies as well as Medicare with regards to, before any surgical treatment can be undertaken, unless there's a significant decline, it is the right thing to do to at least attempt a trial physical therapy. I think people are often surprised at how well they do with it. One thing that I do a lot of and send a lot of people for is aquatherapy. It's often not on the forefront of people's thought processes when it comes to their treatment modalities, but water type classes, water aerobics, or a formal water aqua program from a therapy standpoint provides a significant relief because it allows mobility in a very back kind of environment. And lastly, time oftentimes will cure a significant amount of problems. If we can just provide some anti-inflammatories and some physical therapy and time, a lot of these acute problems will get better on their own. Some of the more invasive but conservative treatment options are the steroid injections, very popular these days. Not everybody is a candidate for injections, and they can range from trigger point injections, where you're simply just finding the site of the pain by palpation and injecting a combination of steroid and pain medicines at that site, looking at epidural injections, which can be broken down either into translaminar, which is more of a global injection where you're bathing all the nerves on the posterior elements underneath the lamina, to a very specific transforaminal injection where you're targeting a specific nerve root, like the image on the top right there. The nerve root is being targeted for a very specific pathology. Somebody that may have a small disc bulge impinging a nerve root, say the L4 nerve root, they can target that. And if we can get the swelling to just come down a few millimeters, that's often all that they need. Also gaining some good ground are the facet injections. Also, not everybody's a candidate for facet injections, but somebody that has a really good looking spine, but a couple very bad facets may be good candidates for a facet injection. And if they get a good response for the injection, then the nerve can be ablated. Again, this is an area where there's a high density of pain fibers from the medial branch off the spinal nerve that goes to the facet joints. And if the facet injection provides good relief, then they may be a good candidate for the radiofrequency ablation. So moving on to try to bring this all together are the cases. And these are people that we, either attempted conservative management or were not candidates for conservative management, and we moved on to the surgical intervention, which are good cases to review and fun to talk about in addition to all the conservative stuff. So this first case is a 24-year-old female who had acute onset, quite intractable low back pain associated with urinary incontinence, bowel incontinence, lower extremity weakness, as well as saddle anesthesia. And these are all buzzwords that everybody should understand and be aware of, that this is something called Cauda-Equina syndrome. Overall, very healthy woman without any significant past medical surgical history. On exam, she was in a significant amount of distress secondary to pain, as well as the current situation. It's a very scary event to start losing these types of function at any age, but much less 24 years old. She had 0 out of 5 strength in her dorsal and plantar flexion on the right. She had 2 out of 5 strength in her dorsal and plantar flexion on the left lower extremity, and she had saddle anesthesia. This is a surgical emergency. If this shows up in your clinic, this is be directed to an emergency room. If it shows up in the emergency room, this is an emergent MRI that needs to happen. And this was her MRI. So on the left, you can see an absolutely enormous disc herniation. She has some degenerative disc disease at the L4-5 and the L5-S1, and some disc bulges, as well as a disc herniation. But you can see spanning between the L4-5 and the L5-S1 disc spaces is an absolutely enormous disc herniation that's taking up the majority of the spinal canal. And on the right there is the T2 axial, and the spinal canal is completely obliterated by the disc fragment. So as I've said before, this is a surgical emergency. If the patient presents acutely, then this needs to go to the operating room immediately. There is no role to attempt conservative management. And that's exactly what we did. The day of her presentation, we took her directly to the operating room after the MRI, confirmed what we thought for an L4-5 laminectomy for discectomy. The way we approach discectomies is through a more minimally invasive technique when there's a good candidate for that. The image cartoon on the screen there shows what we call a tubular retractor, and it allows for dilation of the paraspinous musculature down to the spine rather than stripping the muscles off the spine. Once we get down to the bone, the the procedure is the same as it always has been. It's removal of bone to gain access to the spinal canal. That tubular retractor can be moved up and down quite significantly over multiple levels to gain good access. But it allows us to gain a more focused approach to the spine. And she was a good candidate for this. As expected, we found a massive disc herniation, which was removed. She had quite a prolonged recovery over the course of over a year. We have seen her back. She has gained a significant amount of return of her function. She has some mild residual weakness of her distal dorsal and plantar flexion. Her bladder function has returned. Unfortunately, her bowel function remains impaired, but she is highly functional on a day-to-day basis. Moving on with case 2 is an instrumentation case to discuss. This is a 35-year-old female with several years history of progressive low back pain, as well as predominantly pain radiating into the right hip, leg down to the thigh to the knee. Again, more of an L4 pathology. She denies any weakness except when the pain is severe. She feels weak in her back. When the pain gets quite bad, she does feel weak in the leg. But objectively on exam, she had excellent strength. She was tentative palpation of her lumbar spine. She denied any known history of any trauma and did not have any attempt at any conservative measures. So starting with an X-ray, she did reveal that there was quite a significant pathology. So on the top left image shows a grade 2 spondylolisthesis. Again, this is a slipped bone, and spondylolistheses are graded based on the degree of slip. Grade 1 are 25% over the underlying vertebral body, grade 2 are 50, grade 3 is 75%, and grade 4 is near complete spinal ophthosis, where it's almost tipping off the edge of the vertebral body. The bottom left is an oblique image, and I bring it up because it's oftentimes mentioned in radiology reports, but not often seen much anymore because everybody either gets CTs or MRIs. But the lateral shows what we call the Scotty dog appearance. In the upper vertebral body, you can see that the Scotty dog, which the face is to the right and the legs are going down, there is a collar of the Scotty dog, and that's the pars defect. The vertebral body below, you can see there's no collar on the Scotty dog. We proceeded with an MRI to further characterize the spondylolisthesis, and as you can see, it shows an overall quite healthy appearing spine with a grade 1, almost a grade 2 spondylolisthesis with uncovering of the disc and associated canal stenosis, and the axials show the canal stenosis as well as the foraminal stenosis. She's a young, healthy individual who is neurologically intact, and it is a pain problem. So we really are obligated and should proceed with conservative management. So we sent her for physical and aquatherapy. We discussed different lifestyle modifications, some weight loss. We provided ibuprofen and some occasional muscle relaxers. And all of these did provide good relief. She even went to acupuncture, which I think does play a good role to assist with some of the myofascial pain. I will often refer for acupuncture, especially in patients that have quite good appearing MRIs and are not really candidates for any surgical intervention. Acupuncture, I think, plays a good role as an adjunct for conservative management. She ultimately had continued pain, and we referred for injections, which also did help temporarily. And we were able to manage this for approximately 2 years, which is a good period of time for which she was able to do quite well without requiring any surgical intervention. But ultimately, the pain returned to quite a significant degree. And ultimately, after a lot of discussions, I had no more real conservative management to offer her. We could repeat much of what we had already done, but she felt that she was progressing, and we elected to proceed with surgical intervention. Due to the spondylolisthesis, this was going to require some form of stabilization. And just to discuss a brief bit about stabilization, the spine can be approached from just about any direction depending on the level. The L4-5 level can be approached from an anterior alone procedure called an ALIF, anterior lumbar interbody fusion. It can be minimally invasive. It can be open, where the disc space is removed. It often requires vascular surgery to assist with the approach, and an anterior plate and screws on the front, very similar to what we do in the anterior part of the neck. On the top right is shown a transforaminal interbody fusion, where we approach everything from a posterior approach, where we're removing a significant amount of bone and facet joint to gain access to the spinal canal. It is an excellent surgery. We are limited in our corridor with the size of the graft we can put in. The ALIF, we can provide a significant size graft. And then lastly, which has gained a significant amount of ground, is what we call lateral interbody fusion, or an XLIF, or for an extreme lateral interbody fusion, where we approach from the side. It's a minimally invasive approach above the hip bone. Given the location of the L4 disc space, the lateral approach with posterior stabilization is what we elected to proceed with. This allowed for excellent restoration of height and reduction of the spondy. That should be spondy, not spongy. And these are the images intraoperatively. So it's a lateral approach where we access down to the spine and the retroperitoneal space to the lateral aspect of the vertebral bodies. We're going through the psoas. We have to use monitoring to protect the lumbar plexus in this region to gain a safe corridor. A K-wire is put into the disc space, and ultimately, in the top right image, after cleaning out the disc space, a nice sized graft can be placed from the lateral approach, much larger than we can place from a transforaminal approach. And as you can see in that middle image there, it allowed for a significant restoration of height, as well as a near complete reduction of the spondylolisthesis. These do require stabilization. This can either be through a lateral plate or posterior instrumentation. I feel that the posterior instrumentation provides a much better form of stabilization, but many people are also comfortable with a lateral plate. Those bottom two images show the instrumentation being placed using our intraoperative navigation system. Postoperatively, she did very well. She did not need a decompression, which saves operative time, as well as morbidity from decompression because of the indirect decompression that you can get with restoration of height. Postoperatively, she was quite sore. These are painful operations. We've gotten much better with pain control, but compared to preoperative status in the appropriate patient, the soreness is operative and gets better with time, and her back and hip and leg pain were markedly better within 24 hours of surgery. So in summary, back pain management can be very challenging. It's something that we see on a daily basis. It's our most common reason for being consulted on an outpatient setting as well as an inpatient setting. Trying to sort through the underlying cause of the back pain, the treatment management options, should be conservative to start with. If there is a progressive neurologic decline that we described in the first case, or even an acute neurologic decline, then oftentimes directly to surgery is the very appropriate option. But for a chronic problem that has not had any conservative management, starting conservatively with a non-operative management is the right thing to do, and is often mandated by insurance companies as well as Medicare. The majority of chronic back pain really is non-operative. I think that the operative interventions are really big operations. The discectomies are in the minimally invasive approaches often are very satisfying, but the larger surgeries that do require instrumentation really should not be taken lightly, as they do work, but can have downturn effects, from a lifestyle standpoint, as well as problems, 5 to 10 years down the road. So they should not be taken lightly. So I hope this has provided a good summary of how we manage back pain. If there are any questions, if there are patients that anybody would like to discuss, my cell phone is on the screen. I would love to hear from anybody with regards to any management discussions. We're happy to see anybody at any time. Please call if anybody needs assistance. Thank you very much.
So we have a few questions that have come across during the presentation, and I'll just run through them and hopefully try to answer them pretty straightforward. The first one, should PT be the first line of defense / response, and what indicators should prompt skipping straight to a consult? As kind of indicated during the presentation, I think that physical therapy plays a very strong role in my practice, and I think just about anybody that treats the spine. It's reasons to go straight to a consult and avoid physical therapy would be if there is quite a significant neurologic deficit. I think that should prompt a direct referral, and if quite severe, like one of the cases we mentioned with regards to the cauda equina, that may deserve an emergency room visit. But I do feel strongly that physical therapy does have its role. And sometimes it's just a matter of trying to get the pain under control first with the anti-inflammatories and then move on to the physical therapy so the physical therapy can be more productive. So hopefully that answers that question. Second question, recommendations for acute non-specific low back pain without any red flag symptoms, assuming no neurologic deficit. Is there preferential treatment based on available evidence for either oral steroids or IM steroids versus muscle relaxers? I think that IM steroids definitely have a role. They allow kind of to pack a punch initially, but the oral steroids, like the Medrol dose pack, will provide a more long-lasting effect. Usually, what I'll do is start with a Medrol dose pack oral steroids, and as the patients are getting down to the lower doses, as it's a self-weaning pack down to the last 1 or 2 days, then we'll start up some over-the-counter anti-inflammatories like Aleve or Advil to continue that anti-inflammatory effect. And muscle relaxers definitely play a good role. Methocarbamol is a good muscle relaxer. Most oftentimes doesn't provide or doesn't cause any sleepiness. Flexeril is also very good, but can make people somewhat drowsy. But I think muscle relaxers also play an excellent role in managing that acute pain. Moving on to the third question, is there a standard thought that PCP/GP should follow when they are presented with a patient struggling with back pain, when to send to either ortho, PT, neuro for a spine consult? I think that hopefully the presentation kind of answered that question. I think always start conservatively. We are happy to see anybody at any time, and sometimes patients just would like a referral to put their mind at ease. I think that starting with basic X-rays to ensure we're not dealing with something significant like a fracture is very good. And if nothing's seen there, then often start with the physical therapy and the anti-inflammatories. And if that's not working, then a referral to us to move on to the next stages, and imaging is great. If imaging can be obtained first, that's fine. But if there's no imaging, then oftentimes we can forge ahead with that. The next question is, what is the process for referral to aquatherapy? Aquatherapy is kind of has different levels. Some physical therapy places do have an aquatherapy with regards to oftentimes a treadmill and a hot tub to allow for a more weightless environment. I think that places that actually have small or large pools for a very encompassing aqua program often provides a little more benefit. Both you can have massage in the water, relaxation in the water, along with activity in the water. So hopefully that answers that, but oftentimes it can be done through PT, and not everybody has access to aquatherapy. And in that case, sometimes the physical therapist can recommend some aqua exercises for a home pool or a neighbor's pool. Where do I like to refer for acupuncture? Brett Moldenhauer is my go-to guy with regards to acupuncture. He's local. He's very good. If he's not gaining ground on you, he's not going to continue on multiple sessions. But he's very conservative. And but there are also multiple other acupuncturists in town. And lastly, in the last few seconds, traction. The traction is often used and can help with acute pain for the decompression therapy. Thank you all.